It's my pleasure to introduce Tim Asmis. Tim spoke at our conference in the past. He is a medical oncologist in Ottawa. He's done all of his training for internal medicine and his medical oncology fellowship in Ottawa, and then went to Memorial Sloan Kettering for his GI oncology fellowship. He is a member of various committees at CCO, the OMA, and medical staff at his hospital, and he also has a keen interest in clinical trials. And he'll be speaking twice this morning, but the first talk is dedicated to an update on neuroendocrine tumors.
All right. Thank you so much, and thank you to the organizing committee for inviting me today to talk about this really quite exciting topic, and that will be on the new developments in the care and management of patients with gastroenteropancreatic neuroendocrine tumors. So these are my disclosures. So the organizing committee asked me to go over a few objectives this morning in my talk. And so what I will do this morning is review the updated terminology and classification for neuroendocrine tumors, provide an overview of the presentation and diagnostic workup of NET, and I'm going to do that through a few interactive cases that we've seen in Ottawa. And I'm going to discuss treatment options and their availability, as well as management of symptoms and complications of neuroendocrine tumors, look at clinically relevant endpoints such as response rates, and also discuss the common toxicities that we see from these treatments and as well as their management. So I'm happy to report there's been a lot of progress in the land of neuroendocrine tumors. And this slide really kind of shows this fairly 100-year process where the old Professor Oberdorfer back in Germany coined the term carcinoid or cancer-like. And then we started to see the somatostatin analogs come into practice in the 1980s. And then as we entered the new millennium, the WHO took this on, and we had the first classification of neuroendocrine tumors and neuroendocrine carcinomas. And then we just saw the European community organize themselves to form the ENETs. In North America, we have established a community called NANET, so it's the North American Neuroendocrine Tumor Society. We have annual meetings. Our meeting is next weekend in Seattle, Washington, where investigators and thought leaders in neuroendocrine tumors come together on an annual basis, develop guidelines, work on clinical trials, and really kind of advance development for our patients with neuroendocrine tumors. And then really over the last few years, we've seen a fair explosion of new therapies, and I'm going to do my best in my 45 minutes allotted today to kind of touch on each one of these and to show you really where we've come in the treatment of neuroendocrine tumors. So with this explosion of data, I'm lucky enough to have some very learned colleagues across the country. We meet regularly, and we come up with these consensus guidelines to help guide management of patients with neuroendocrine tumors in Canada. So the first one that was done was back in 2010. This one's from 2014. We recently updated that in 2016. And really what we're trying to do, even at the expert level, is just synthesize the data and make clear recommendations for practitioners across the country for optimal care of our patients. What's amazing with this process is the collaboration that we have, but also the need to keep investing energy every couple of years to update these as the landscape broadens and more options are available to our patients. So I always like to take this opportunity to thank the multidisciplinary collaboration that I have in my center in Ottawa, but as well as clear across the country and really around the world these days. And when the exciting thing about neuroendocrine tumors is that it really does take a team. So it's a multidisciplinary team that involves the surgeons, pathologists, radiation oncology, nuclear medicine, cardiology, nurses, allied health professionals, GPOs, pharmacy, drug navigators. We're all in this together for our patients. So let's just start with a case. I always like to focus some of my talks around a case just to give a bit of a practical aspect to this. So this is a 49-year-old female, had a past history of hypertension. She had this 2-year history of diarrhea and flushing. And this diarrhea, she went to the doctor a number of times and described it being about 8 to 10 per day. She had abdominal pain. She had this sensation of facial flushing, and this is a nice image of facial flushing here. On exam, she was sitting in front of the physician, and the face actually literally becomes pink right in front of you and then kind of goes away. However, her chest is clear, heart sounds are normal. On abdominal exam, the physician detects a bit of hepatomegaly. So the patient, like I said, saw a number of different doctors, went to an allergist. Somebody ordered a urine 5-HIA, and it was dramatically elevated. So what syndrome is this? And this is the so-called carcinoid syndrome. So what percentage of patients have this symptomatic neuroendocrine tumor? So whenever I'm talking about this tumor, we still like to use this kind of flow diagram to kind of divide these up between gastrointestinal and pancreatic neuroendocrine tumors. And we like to say that there are functioning ones and non-functioning. And I've kind of illustrated the percentage of functioning versus non-functioning. So the case I just described actually is the minority of cases. So most people have non-functioning tumors, but that certainly was the classic carcinoid syndrome. We think that is a result of serotonin secreting tumors. But of course, there are a number of other tumors that are out there, those which make insulin, those are insulinomas, those that are involved with gastrin production, and that's gastrinoma. So just always kind of walking through this. So what is urine 5-HIA? It's a cornerstone assay we've had for 30 years, and really it is a net biomarker, if you will. It's a very inconvenient test. You know, whenever you write this on a lab rec, the person has to go down lab and get a bucket and walk around for 24 hours with this bucket to collect all their urine, and they have to bring the bucket back to the lab. So people don't like doing that. However, it provides some useful prognostic value. And really, I put the tryptophan to serotonin pathway and how that results in urine 5-HIA. And we do think that's an important biomarker, and we do that routinely for our patients, both at diagnosis and also in follow-up. So back to case DG. So she has the carcinoid syndrome. So where do we think she has her disease? And do we think that she has metastatic disease? Well, you know, I'm awfully worried about that for a few reasons. So going back to this slide that we always have to show, it shows the wide range of syndromes that can be associated with neuroendocrine tumors and where the primary tumor comes from. So we start there with the small bowel tumors. They're mainly the ones that result in the serotonin production. That's the so-called carcinoid syndrome with those symptoms. When we get over to the pancreas neuroendocrine tumors, that's where we start seeing, you know, a whole range of vasoactive amine production, from serotonin to gastrin, VIP, insulin, and glucagon. Now, in my practice over 10 years, I have seen, you know, the predominance, of course, is the serotonin one. I've only seen one insulinoma. I've seen one VIP-oma. So these things are very rare, and you'll probably go your whole career without seeing these, but we do have to mention these. So this 49-year-old female has a carcinoid syndrome. She has high urine 5-HIA. What other tests do we want to order, and what systemic therapy do we want to initiate are the obvious questions. So we do a CT scan. A 2.7 centimeter lesion is found in the small bowel, but there's multiple lesions in the omentum. There's lesions in the liver. It's biopsied. Your pathologist gives you a nice report that says it's a well-differentiated neuroendocrine tumor. Ki-67 is 2%. You order an octreotide scan, and this shows strong uptake in the liver plus mesenteric lymph nodes near the ileum. You also do a chromogranin A level, and that is also elevated. So this is all very typical of a workup of a patient with metastatic neuroendocrine tumor. So there are a few, well, there's this new test that's out there. This is available in Canada now, currently in Toronto for patients on protocol, and also in Sherbrooke, Quebec. So it's called a gallium-68 dotatet PET. And this is an amazing piece of technology that's been around for 10 or 15 years, relatively new in Canada, that is amazing at detecting these neuroendocrine tumors. Now, I'm not a nuclear medicine specialist, but I've seen, you know, these presentations presentations where they show a gallium-68 scan up beside an octreotide scan, and my somewhat analogy, it's like going from like an old black and white TV to ultra high def. You know, the stats are there. Most of the lesions are seen with gallium-68, whereas with the octreotide scan, it's down to 30%. So really, we find that this is a useful test for determining where all the sites of metastases are. And I think this is particularly important in those patients where local regional therapy like surgery is going to be undertaken, so you can debulk most of the tumor that is there. So let's change tacks here and talk about classification. So as mentioned, over the last 20 years or so, the WHO has taken an active role, meeting every 10 years or so to determine this classification. So this is the 2010 classification, of which most of us are familiar with. They recently updated this, of course, so I'll go over the differences in just a second here. But we still talk about so-called G1, G2, and G3 neuroendocrine tumors, looking at the grade. And one of the indicators that we use is the Ki-67 and mitotic rate. There's a bit of a reference there that those patients with the well-differentiated low Ki-67 or G1s tend to have a favorable prognosis and sometimes can live for years, even decades. But of course, the patients with a high grade or the high Ki-67 tend to do really quite poorly. So recently, the WHO revamped this with this, a fair amount of it reads the same, but there's a subtlety that you can have a well-differentiated G3 neuroendocrine tumor, and the observation for those of us treating this is that those patients probably don't benefit from chemotherapy as much as the high-grade, high Ki-67. So that's just the subtle difference in 2017 that we've started to use. So what about other biomarkers? Going back to our case, we did this test called the chromogranin A. It's highly sensitive and specific for neuroendocrine tumors, this is available routinely across the country. So, and this is the sensitivity and specificity of chromogranin A and urine 5-HIA. So these are two tools that we use. So now one of the key points we always have to mention is that the chromogranin A can be elevated in other conditions, including other malignancies. A very common one, of course, is patients who are on a PPI. So if they're on a PPI, they may have an elevated chromogranin A, and it may not mean that they have a metastatic neuroendocrine tumor. So we always have to watch out for that one. So back to the case. So this patient is still having crampy abdominal pain. She's booked for small bowel resection in 3 weeks. They come to see you in the clinic. What are you thinking about, and what is, very important? And some leading questions here. So what crisis are you worried about here, and why would we do surgery for this patient? So there's a lot of tools for patients with metastatic neuroendocrine tumors, and I'm going to start to touch on those now. So of course we have somatostatin analogs. They've been around now for about 30 years. We have good old-fashioned surgery. It's been around forever. And there's resection of the primary tumor, as well as metastacectomy, or even so-called debulking procedures. There's liver-directed therapy. So, we have chemoembolization, so-called bland embolization. That's like chemoembolization, but you're not using chemotherapy. Yttrium-90 is used widely across the United States, not so much in Canada. Radiolabeled therapy, so-called PRRT, and I'm going to go into that later on in the talk. And then agents that we're fairly used to using in the oncology clinic, so-called targeted therapy, with fairly recent Health Canada approvals of everolimus and sunitinib. So I kind of put this slide on a bit of a circle diagram, if you will, because what is unclear is, where do you start and where do you go to next type thing. And I'm going to spend a bit of time, using a case to illustrate which one of these we pick at which time. So first of all, why surgery for this patient? The patient has metastatic disease. There's lots of cancers that we see where we don't offer surgery. But the surgeons, and we have some great academic surgeons here in Canada, have shown that surgery can improve quality of life and symptom control. The primary sites, so say like a terminal ileal carcinoid tumor, that can cause patients significant morbidity as the years go by because it can be associated with this mesenteric fibrosis, which can result in bowel obstruction. Many times when patients go for surgery, they take the gallbladder out, do a cholecystectomy, because many of our therapies, like the somatostatin analogs, can result in bladder stones and sludging and symptoms. And there is a thought that this may actually be skewed towards improved overall survival. And there are some patients out there who are potentially cured with resection. And I even have one patient in my practice who received a liver transplant for liver-only metastatic, well-differentiated neuroendocrine tumor. He's going on about 6 years now and remains disease-free. So those are definitely options that you need to discuss with your patient. So back to the case, 49-year-old female, classic carcinoid syndrome, metastatic disease, elevated urine 5-HIA. We did an echocardiogram. Now, why did we do this? And I'll answer that in just a minute there, but just get you thinking about that. So this patient is sitting in front of you, surgery's 3 weeks away, having a lot of diarrhea, carcinoid-like symptoms. So we start octreotide LAR to improve these symptoms, and we refer the patient to anesthesia. And remember, I referred to the so-called crisis, and the crisis that I'm referring to is a so-called carcinoid crisis that all surgeons and anesthetists fear, and that's when they're manipulating the tumor, and you can have massive release of serotonin, and patients can become hemodynamically unstable in the OR. And we think that octreotide LAR and short-acting can prevent this, so it's very important to have your patients on that. So in terms of starting doses for this, there's a number of studies that are out there, but thankfully we have this regular Canadian consensus where we've agreed that octreotide LAR 20 to 30 milligrams every 4 weeks is the right dose. We have a new tool that's called lanreotide, another somatostatin analog, and the dose of that's 120. It's given deep sub-Q every 4 weeks. And then there is an ability to titrate these medications. However, what I always have to warn everyone is, of course, this day and age, this is not indicated by Health Canada. This titration is something that's commonly done in the clinic. And there is some data to support this, but not in terms of randomized data. Of course, short-acting octreotide, it's been around for 30 years. It still is an important tool for patients who need to be so-called rescued from their carcinoid-type symptoms. And then we have some new treatments out there, like telotristat, of which I'll go into in just a minute. Some older players out there, interferon alpha, very uncommonly used these days. Of course, local regional therapies like surgery and hepatic arterial therapy. So, of course, when we're talking about symptoms like diarrhea, it's a relatively nonspecific symptom. We always encourage the clinician to look at the diarrhea and rule out other causes. But there is this phenomenon of a patient who's optimally dosed on a somatostatin analog who still has carcinoid-related diarrhea. So there was a clinical study looking at telotristat, and it's been recently FDA approved for patients with carcinoid syndrome diarrhea, yet is not Health Canada approved, and I'll go over some of that data now. So this was a relatively large study in the land of neuroendocrine. It is still a relatively rare tumor. And these are patients who are on a regular dose of somatostatin analog, had a history of the carcinoid syndrome, yet still were having an unacceptable number of bowel movements per day. So it was a randomized study between placebo and 2 doses of the telotristat ethyl. So what is telotristat ethyl? So it's a small molecule oral TPH inhibitor. And again, I put that diagram of the tryptophan metabolism pathway. So it kind of interferes with that and leads to less serotonin. And the surrogate for that is you can see a drop in the urine 5-HIA. Now, what's interesting about this is that this is not a new mechanism. This was known about in the 1960s and was tried with a molecule that cross the blood-brain barrier. And as most of you are family physicians, you know the very important effect of serotonin in the brain and when it comes to depression-like symptoms. And this strategy was abandoned in the 1960s because it led to just intolerable levels of depression in patients. But they perfected this with this molecule that it does not cross the blood-brain barrier, and they were very much looking at depression symptoms as a relevant toxicity. So what they found was that on average, if someone's having 6 bowel movements a day, it drops down to around 4. It was statistically significant, and when you talk to patients with this, this may be the difference about the ability to, get out to a birthday party, get out to the mall, and with an improvement quality of life. So as the surrogate, as I mentioned, we saw a reduction in the urine 5-HIA in most patients. All right, so moving along there, I'd mentioned about this carcinoid crisis, and again, I always like to, add this in there because occasionally you will receive calls from your anesthesia department saying, hey, what should I do about this? Now, every anesthetist in Canada knows about the carcinoid crisis. It's on their board exams, I'm assured, but still, they sometimes do call the cancer center to get some advice here, and we need to know about it. Your anesthetist needs to know about it. They need to have short-acting octreotide on hand when they do these cases, but most of these surgeries are happening in big centers where they're really quite familiar with this. So I mentioned a little bit about doing routine echocardiograms, and that's because of this phenomenon called carcinoid heart disease. So the pathology here is that you get this thickening of the right heart valves due to formation of fibrotic plaques. We think it's secondary to the serotonin. It affects valve function, leads to valve insufficiency, subsequent heart failure, and some think that it is associated with chronic elevations of 5-HIA. So getting back to the case here, so in addition to symptom control, and again, in this case, this patient clearly was having the carcinoid syndrome, what other goals can you have when using an SSA for these patients? Tumor growth control, biochemical control, quality of life, or of course all of the above. So let's get into that, as this is still the so-called workhorse of systemic therapy for most patients with neuroendocrine tumor. So somatostatin analogs, we think, has a number of activities. Of course, it reduces the neuroendocrine tumor cell's ability to make these vasoactive amines like serotonin, but we also think it slows tumors down, leads to apoptosis, and generally inhibits these neuroendocrine tumors. But of course, that's all great in theory, but what does the clinical trial data show? Does it actually show that that is beneficial? So there's 2 clinical studies that we need to go over. One was the German PROMID study. Now, this was completed about 10 years ago, and this was a study of patients just with midgut neuroendocrine tumors, and were randomized to placebo or octreotide LAR, and so here's the schemata of the study, fairly straightforward, and they were looking for progression-free survival in terms of the primary endpoint. The dose of the octreotide LAR was 30 milligrams, so that's fairly standard, what we use in the clinic. And so what they found was that the use of octreotide LAR significantly prolongs the time to tumor progression. So it was 14.3 months versus 6 months. That's fairly significant, and it was statistically significant. So just a few of the trial characteristics. The arms were fairly balanced. It wasn't that big of a study. There was only 85 people who finally were on that study. But this was our first signal that led to the early adoptions of SSA in most clinical guidelines. So this became a fairly important tool for our patients about 10 years ago. So, of course, we always like to confirm this with yet another study. So this is the Clarinet study, recently published in the New England Journal of Medicine. And this used another SSA called lanreotide in metastatic enteropancreatic neuroendocrine tumors. And this was a randomized study of lanreotide versus placebo. These are patients who had moderately differentiated metastatic or locally advanced unresectable GEP-NETs, I'll contrast these studies in just a minute here. But this study, too, met its primary endpoint in terms of significant improvement in progression-free survival. These results were robust, and statistically significant. So Clarinet was the first phase 3 randomized study to show that using an SSA was beneficial in both midgut and pancreatic neuroendocrine tumors, 53% reduction in risk of tumor progression or death, and was effective despite hepatic tumor volume. So some of the side effects of somatostatin analogs, I always tell my patients it can have some mild fatigue. Interestingly enough, we give these medications for patients who have carcinoid-related diarrhea. But if you have a non-functional tumor, it can actually lead to GI upset, including diarrhea. It can have headaches. As I mentioned, cholelithiasis has been described. So just comparing and contrasting these two studies, as mentioned, with the octreotide study, it was just midgut tumors. With lanreotide, you have midgut, hindgut, and PNETs, and a few of the other subtle differences between those two. So what about watchful waiting? If you notice there, the placebo arm of both those studies, both those arms did very well. And in the Clarinet study, they actually had 18 months before the patients had progression. So a lot of us believe that watchful waiting still has a role in the clinic. But we do need to do this carefully. And what to watch out for, if somebody has an overwhelming burden of disease where any type of progression will lead to clinical deterioration, that may not be the best person to do that, of course. And there are so-called other clinical scenarios that as experts we talk about. But really, this is somewhat of an unclear area, and I think we need to work a bit harder to see who we can watch and wait in and who we need to start therapy early. So back to the case, so they go and do surgery, they do a bypass, they remove the gallbladder because they're worried about long-term toxicity of the SSA. The patient comes out, is back on the octreotide, but is having breakthrough symptoms. So what do we do? And again, do you move to systemic therapy? Do you do liver-directed therapy? Or do you just continue to watch and monitor? So, as mentioned, your options there are increasing the dose of the octreotide LAR, adding interferon or bevacizumab to the octreotide, although that was recently shown not to be effective. What about chemotherapy? What about PRRT? And what about everolimus? So, just kind of removing a few of the options there, especially the interferon, and the chemo usually doesn't work for well-differentiated. So, where do we go next? So here is some of the exciting new data about peptide receptor radionuclide therapy, so-called PRRT, and a bit on targeted therapy. So recently published is the NETTER-1 clinical study. And what this study did is it took patients with progressive neuroendocrine tumors that had progressed on sandostatin LAR and randomized them to a higher dose of octreotide LAR or lutetium-177 dotatate. And again, I'm not a nuclear medicine specialist, but I spent a lot of time with them. Patients received 4 doses of this and were followed for a number of years. So these are the inclusion criteria, so a fairly usual group of patients, well-differentiated, Ki-67 less than 20%. And so this really kind of took our breaths away when we saw this PFS curve. So this shows clearly that PRRT is significantly prolonging patients' progression-free survival, is statistically significant, and is durable for a number of years. And at the time of presentation, they still had not met the median survival yet. So this was a very exciting turn of events for our patients. Interestingly enough, we saw a response rate of 18%, and usually with the SSAs, we didn't really see much of a response rate. So this really was quite exciting. This is now available in Canada to our patients. There are centers that have actually been doing this for a number of decades, including Sherbrooke, Alberta, up in Edmonton there. And in Ontario, we recently had a CCO-sponsored clinical trial that's open where this therapy is available in London, Hamilton, Princess Margaret, and Sunnybrook. And just for those of you who may have patients, I listed the inclusion criteria there because I think this is a very meaningful option for our patients to access. So what about targeted therapy? So I know you may have had other talks at this conference and previous talks about targeted therapy, and you've heard, of course, about everolimus. It's widely approved in other types of tumors. It's an mTOR inhibitor. So this is being studied extensively in neuroendocrine tumors. There were 2 RADIANT studies that came out in the last 10 years. First is RADIANT 2, which was a negative study. Those had symptomatic patients with neuroendocrine tumor, and then of course RADIANT 4 came on after that, and that was for non-functional tumors, and that was a positive study. So I just kind of compare and contrast these 2 studies. RADIANT 2 was done first. It showed a prolongation of PFS, but was not statistically significant and was not further developed for patients with symptomatic neuroendocrine tumors. And then RADIANT 4 came, and they took out the patients with the carcinoid syndrome, and there that they found that the PFS was 11 months versus 4 months, and this was statistically significant, and this subsequently led to the FDA and Health Canada approval. So I'll just walk you through this the study design. It was a 2-to-1 randomization for everolimus. Starting dose was 10 milligrams versus placebo. And here is the PFS by central review, which it does show that everolimus is clearly positive. So this study included a wide range of NETs, including lung NETs, GI or unknown primary, and there tended to be a benefit in both the lung and GI subgroups. So back to the clinic, back to the patient in front of you. You now have 2 approved options for these patients. PRT, which is now FDA approved, of course not Health. It is Health Canada approved, but it's a case-by-case basis. And then, of course, you have everolimus, and we kind of listed the criteria there. Personally in Ottawa, we have a very successful collaboration with London, Ontario. I'm sure the Toronto group also has their own connections with PRT. But just to remember, this is accessible across Canada, and I think does provide a meaningful benefits for our patients. All right, so a few questions here about systemic therapy, but we'll just move past that one there. So in summary, there's more therapeutic options for these midgut neuroendocrine tumors. Sequence of therapy is becoming better delineated. So of course, most would recommend first-line treatment with an SSA and further therapy that can be targeted towards the disease itself. But then there are other options with PRT and everolimus. So I only have about 10 minutes left there, and I know I'm covering a monster amount of material here. But as I tell my medical students, isn't this great? I have so much to talk about because there's been so much development. But again, the organizing committee has charged me with the task of trying to cover it all, and hopefully, my slides will be available, and I'm always available to chat more about this as we go along. But I do want to touch on the subgroup of neuroendocrine tumors, which are pancreatic neuroendocrine tumors, because they're different, and there are some different treatment options for our patients. So again, let's go to another case. 52-year-old man shows up with abdominal pain. They do a CT scan. He's got this mass in the pancreas, and he's got a bunch of liver lesions, but he's not having the carcinoid syndrome. He's told by the emergency doctor, you have pancreatic cancer. He's devastated by that news. But of course, go and do a biopsy, and it comes back as a well-differentiated neuroendocrine tumor. What do we do now? So you ask your pathologist to look at it again. They say, oh, it's a Ki-67 of 10%, so it's a G2. You do an octreotide scan. You present the case at tumor boards. He's not a candidate for regional therapy. So what do we do next? So what systemic therapy has randomized, controlled trialed, level 1 evidence for pancreatic neuroendocrine tumors? And I keep updating this talk, and more of this turns red. So here we go. So you have 4 treatment options here for this patient, supported by level 1 evidence, and I'll just breeze over that now. So back to the clarinet study that I had mentioned before for the midguts. That also included pancreatic neuroendocrine tumors. And so most people would argue that that lanreotide would be indicated as the first treatment. It's just a once-a-month injection. It doesn't have the same toxicity as the other treatments I'll mention. So, but what about targeted therapy for progressive NET. So back in February of 2011, the New England Journal published these 2 randomized studies back-to-back showing the role of sunitinib and everolimus for these patients. And that was the so-called RADIANT-3 study. And sunitinib also had its own study there, of which I won't go over all the details now. So there were similarities in these pancreatic neuroendocrine tumor studies, and this leads to a lot of discussion, even at our consensus meetings, about which one you use first and what you do. So both have quality of life data, both have a progression-free survival data, both are Health Canada approved. So it's one of those difficult discussions where we look at that. So just a bit about the data. Everolimus has some robust long-term data now showing that, that patients do well for a long time. There was crossover in that study, so that's why those lines get a bit blurred there. But I think we kind of put this up for encouragement, showing that a lot of patients are living for a long time, this time with sunitinib. So maybe there's a role for both of these, and maybe there's a role for sequencing is really what we're saying. So of course, we always have to talk about patient preference, comorbidities, toxicity profiles, tolerance. Availability is a big issue across the country, and sequential therapy should be considered. So I like to kind of put this up here and say, well, how do we decide? And, so all of us, who've been doing oncology for a while know about everolimus, know about sunitinib, we know about the toxicity. Patients with uncontrolled diabetes, maybe you want to think twice about using everolimus. You worry about lung disease with everolimus. Of course, with sunitinib, you worry about uncontrolled hypertension and the cardiotoxicity that patients can experience when they go on sunitinib, and of course, hand-foot syndrome. So I think those are all very important things to talk about when you're deciding on therapy. But my last few minutes here, I would like to bring the audience up to speed with some very exciting, very new randomized data that we just learned about just a few months ago at the 2018 ASCO meeting. So ASCO colleagues, Pam Kuntz and colleagues, reported on this randomized phase 2 study of temozolomide or temozolomide and capecitabine in patients with advanced pancreatic neuroendocrine tumors. So this was an intergroup study done in the US. The study was 140 patients randomized to either temozolomide or TEM-CAPE. The TEM-CAPE is given on a 14-day cycle, so you give the capecitabine for 14 days. You add the temozolomide in for day 10 to 14. The primary endpoint was progression-free survival, and of course they looked at the relevant secondary endpoints. And the group was, the audience was very impressed by this progression-free survival of 22 months in the patients who received TEM-CAPE versus 14.4 months in patients who just received temozolomide alone. And in terms of overall survival, it's not reached yet for the TEM-CAPE arm, which is always amazing to see at these studies, So in conclusion, temozolomide and capecitabine, relatively older oral medications that have been around the clinic for probably over a decade, demonstrates improved progression-free survival, so 22.7 months, and that's the biggest number we've ever seen in PNET before. Remember the other studies I was showing you was like 4 versus 11 months or something like that. The response rate is really quite high, so it's 30%. The adverse events are fairly similar to what we've seen with these chemotherapies before, and they're going to do some pending analysis based on a few other pre-specified measures. So key take-home points are that pancreatic neuroendocrine tumors can behave more aggressively than midgut neuroendocrine tumors. We have a swath of therapy that's available to patients now, including somatostatin analogs, everolimus, sunitinib, now capecitabine and temozolomide. Interesting enough, south of the border in the US, the FDA has approved PRRT for patients with PNET as well, in the absence of any data. We'll see how Health Canada is going to react to that. There's no consensus when to give chemotherapy, but this, of course, should be considered for the G3 nets. But now, I think as a neuroendocrine tumor community, we're digesting this CAGPO data and saying, is that actually our best foot forward with this patient population in terms of response rate and PFS? So with that, I know I've covered an enormous amount of data, but I'd like to take a few questions, and thank you again for your attention.
Thank you. So we have time for a few questions. While smarter people than I on this subject are coming to the microphone, I'm just going to ask. So I work in mostly breast and a bit of lung, and a lot of the pathologies now seem to have some neuroendocrine differentiation in the pathologies, which seems to be a higher frequency than, say, 10 or 15 years ago. Why is that?
So great question, and so I did address that on slide number 33 or so with the, and I know I had 95 slides there, but so the WHO in their recent 2017 classification had this new thing called mixed neuroendocrine tumor and carcinoma as a separate subtype. So if you get a room of pathologists in front of you, of which I've done in the past, they will argue amongst themselves about where that fits in and this type of thing. So I think the pathology community is very much aware of that. The other kind of somewhat controversial subject that I didn't touch on is in lung neuroendocrine tumor. I think there's these two camps of pathologists. There's lung pathologists and there's GI pathologists, and even they collegially disagree about how they should still label these tumors even to this day. In lung you hear about things even called atypical carcinoids and large cell differentiation. So I think we need to really engage our pathology community. I think there's a great importance for multidisciplinary tumor boards where you actually get your pathologist to explain what they're seeing, and so on a case-by-case basis you can risk stratify. So for example, I recently had a patient with colon cancer, and the colon cancer, the adeno component was 5% of the tumor, but the high-grade neuroendocrine component of the colon cancer was 95% of the tumor. So, good luck. What do you do with that one? And so we discussed it at tumor board. We tried to pick the best chemo that will address both of those. So I think the pathologists are spending a lot more time looking at these cases. They're becoming very sophisticated, and so I think we're starting to see that come out in these pathology reports, and it is interesting what to do with that. So,
Lucille, you must have a question.
So Lucille's my partner in crime, full disclosure. So she helps me meander through this on a day-to-day basis. So thank you, Lucille.
So in your pancreatic with liver mets, if they're octreotide scan negative in terms of liver uptake, is this temozolomide and capecitabine still indicated?
Well, we think it is, yeah. So the majority of those tumors, I think, are not avid on octreotide scans. And
okay, so I have a patient who has a neuroendocrine tumor of his thymus that with liver mets, and the biopsies have been repeatedly done by liver, and we've been through now 3 lines of chemo, and they recently tried to restage him with octreotide, and it was negative for the liver, so they shut that down as the thymic lesion is not progressing, but his liver lesions are progressing. So otherwise, well, still trying to play golf. And I just wondered, can I poke at the oncologist and say maybe we should be trying capecitabine and temozolomide? Do you think there's an extrapolation there?
Oh, so that's a great question, and one of fairly enormous controversy. So this study done in PNET was exclusively PNET tumors. There's been some other data out there for neuroendocrine tumors of other primary tumors, and there was a very controversial presentation at ASCO a few years ago where Dr. Fine and his colleagues from Columbia, they still haven't published this data, went up to the podium and reported on a 96% patient improvement rate with CAGPO for their patients, regardless of primary tumor. It was a small study, it was widely criticized, so we really don't know what to do with those other primary tumor sites. I guess my other somewhat piece of advice there would be, in this day and era of PRRT, you know, what is the gallium-68 dotatet say? It's available, compassionate access in Sherbrooke, and if that was positive, could that patient be a candidate for PRRT at one of the PRRT centers? That's stretching it a bit, I think, but again, you know, so.
The oncologist talked him into paying the 10 grand to send tumor down to the States to have a expanded oncogene panel in case we would get some targeted therapy options. So that's where this is, but I'm not sure how long that process takes. But
Yeah, you know, more and more we see that with our patients these days, and it's hard to say.
Okay, I think we'll end now, and anybody, I know there's always a few shy people who don't want to come to the microphone but always come up after, so if you have a question for Tim, just come up.